Okay, moving on to disorders of the gallbladder. So why do we have a gallbladder? Bile is formed in the liver and it's stored in the gallbladder. Food entering the intestine stimulates the gallbladder to contract and release the bile through the common bile duct and the sphincter of Oddi into the intestines. There are 3 types of disorders associated with the gallbladder. So remember the terminology that I have posted on the guided notes in the first PowerPoint for this section, but I also want you to know these 3 terms. And you're going to see a lot of these are going to be pretty common as far as the suffix is concerned throughout the remaining sections that we go through. So the first one, cholelithiasis, that's going to be a formation of stones within the gallbladder or the biliary duct system. So this part of the word literally means the formation of stones. So it's going to apply, the lithiasis part is going to also apply when we get to the kidney. So just keep that in mind. Now, the cholecystitis, the cystitis part is going to be an inflammation. So that would be an inflammation of the gallbladder, because the chole part refers to the gallbladder and the cystitis part refers to the infection. And then here with this last one, we've got an inflammation of the duct. So that's going to be of the duct of the gallbladder. So just be aware of those 3 terms. Risk factors for cholelithiasis. And remember, that's going to be gallstones. So age is going to be one of your risk factors, as well as family history. Race or ethnicity, so Native Americans, Northern Eastern European heritage. Obesity, and that's because of the hyperlipidemia. And the hyperlipidemia, we have an increase in the total amount of cholesterol. So rapid weight loss, when you think about this, think about your low-calorie diets. They create a higher level of cholesterol in the bile and decrease the gallbladder contractions. Female gender with the use of oral contraceptives, and then biliary stasis. So that slows down the emptying of the gallbladder, and this can happen during pregnancy, fasting, or prolonged parenteral nutrition. And that's the nutrition that we as medical professionals are providing to the patient. And then diseases or conditions like cirrhosis, ileal disease, or resection, sickle cell anemia, and glucose intolerance. This is a big deal for people with history of alcoholism. They a lot of times end up with some gallbladder disease. And then physical activity. So that physical activity is very important for a lot of things about health, but we want to make sure that we encourage an active lifestyle with these patients. So again, cholelithiasis, that's going to be the stone formation. And this happens from abnormal bile composition and excessive cholesterol. So how the stones are formed. When we talk about abnormal bile composition and excessive cholesterol, that's going to come from your diet, what your patient is ingesting. Think about what I said related to alcoholics being at high risk for developing cholelithiasis. So any type of biliary stasis or inflammation is going to help lead to gallbladder disease, and that's from a slowing down of the emptying of the gallbladder. This contributes to cholelithiasis because the stones form in the gallbladder because the gallbladder doesn't completely empty, and this allows cholesterol to concentrate and increases the risk of stone formation. So if it's just kind of sitting in there and it's kind of being sludgy, it's going to start to form stones. And then inflammation of the gallbladder, and this can lead to bile salt reabsorption. So most stones consist of cholesterol, and that is related to diet, obesity, and a high-calorie, high-cholesterol diet. Cholelithiasis. So the common locations for cholelithiasis are going to be in your cystic duct. Your gallbladder is going to be the most common, and then followed by the common bile duct. So we have here, here, in here for the common bile duct. And I want you just to look at this picture a little bit, because later on when this patient ends up having to have his gallbladder removed, a lot of times they leave this common bile duct and they might still have symptoms if there's a stone stuck in there. And then we have cholangitis, and that's the development of a duct inflammation due to stones migrating in the ducts. So this is, sometimes they just don't take those out either, so just be aware of that when we get to the surgery portion. So their pain, they're going to have a pretty abrupt onset. It is severe and steady, and it's localized to the epigastric area and the right upper quadrant of the abdomen. The pain often begins suddenly following a meal and may last as long as 5 hours. They might even have some radiating pain to the back, the right scapula, and the shoulder. That's why doing a thorough cold spa is always important to get all those qualities of pain. A lot of times, along with their pain, it's going to trigger some nausea and vomiting for associated symptoms. So complications of this, they could end up with cholecystitis. That is the inflammation of the gallbladder. They could have common bile duct obstruction that could lead to jaundice and liver damage, and that causes the bile to reflux back up into the liver. And a common duct obstruction with pancreatitis. And pancreatic enzymes will not be able to pass through and enter into the small intestine. Biliary cirrhosis is also a concern, and that's an obstruction that leads to liver damage because the bile backs up into the liver and then damages the liver cells. Cholecystitis, and that's going to be your inflammation of the gallbladder. In some of these manifestations, you're going to see a lot of crossover here. So we still have abrupt onset, it's still severe and steady, and it's generalized to the right upper quadrant of the abdomen. It may also radiate to the back, right scapula and shoulder, and this can last from 12 to 18 hours. It is also aggravated by movement, such as breathing. I've had some patients that tell me that bending over is quite uncomfortable when this is going on. Other associated symptoms are going to be anorexia. These patients are not going to want to eat because they just don't feel good. Nausea and vomiting. And then they're going to have right upper quadrant tenderness with guarding. And then they're going to be progressing to having chills and fever. You might also see some alterations in their labs, like an increase in their WBC count. There's a couple different types of cholecystitis out there. You're going to have the acute cholecystitis, which is due to an obstruction of the common bile duct, and that's going to be from a stone. This increases pressure on the gallbladder, causing ischemia of the gallbladder wall, and it can result in necrosis. So chronic cholecystitis, that results from repeated bouts with acute cholecystitis, and it's often asymptomatic, meaning those patients are not going to have all of these associated symptoms with it. So complications from this, they can have gangrene with perforation and peritonitis. So gangrene can happen in your internal organs too, as well as necrosis. And then the perforation, if it does end up perforating, all of those contents are going to be leaking into the abdominal cavity and causing peritonitis. It could also lead to chronic cholecystitis, like what we talked about, empyema, fistula formation, and gallbladder ileus. So the empyema, that's a collection of infected fluid within the gallbladder, and the gallbladder ileus is going to be an obstruction of the small intestine by a large gallstone. So diagnostics with these, I kind of mentioned this a little bit earlier. They're going to do a CBC, or a complete blood count, and they're really looking at the WBC, the white cells, to look for infection and inflammation. A lot of times they're going to do a differential with this, so they can look at those immature white cells or the bands. They'll be doing a serum amylase and lipase to evaluate for any possible pancreatitis, and then a bilirubin. So they're going to check for elevated or direct conjugated bilirubin, and that may indicate an obstructed bile flow in the biliary duct. These patients will have an increase in alkaline phosphatase if they have a blockage of the common bile duct. Also, they might do a stool evaluation, and if stools are clay-colored, that means that there's a biliary obstruction requiring rapid intervention. An x-ray might be ordered, and you can see here's quite a few stones in this gallbladder. And this kind of looks like bones to me, and there's a reason for that. This particular stone is formed by high levels of calcium. So it's always important to know what the stone is made of to determine how to treat this patient in the future, although they probably had their gallbladder removed. So they could be doing an ultrasound of the gallbladder, and that's very non-invasive. Not to say it's not painful, because they're going to be pushing down on the abdomen, and if they have an inflammation in there, it's going to hurt them. So this is a non-invasive way that can accurately diagnose cholelithiasis. My words are not coming out right today. Cholelithiasis is better. And this diagnostic has replaced a cholecystogram. And here's an example of an ultrasound that shows a gallstone in that picture. And this can also assess the emptying of the gallbladder as well. This exam here is called a cholecystography. You may have also heard it referred to as a HIDA scan. So this is when they're going to be injecting the patient with a radioactive dye. And this is used to diagnose cystic duct obstructions and acute versus chronic cholecystitis. The procedure takes about 2 hours, and the patient must be in PO after midnight. In addition to this, you want to make sure that you're not giving these patients morphine, because a lot of times during a HIDA scan, they will give them morphine because it makes things contract in the gallbladder. So morphine's not going to be your #1 recommended drug if this is suspected. So different medications that they might use for this. We have Actigol and Chinix, and those really reduce the cholesterol content of the gallstones, and that gradually does dissolve them. It's more effective with stones that have high cholesterol content, and it's going to be less effective with stones with high calcium content. The side effects of the Chinix are going to be diarrhea, and they're also hepatotoxic, so you need to make sure that they're watching liver enzymes with that. Antibiotics, if infection is suspected, if they have cholecystitis, they're going to be giving them antibiotics. And then questrin. So questrin's going to bind with bile salts to promote excretion in the feces. This is used for clients with pruritus due to obstructive jaundice and an accumulation of bile salts on the skin. And sometimes they will continue that therapy for quite a long time afterwards. Narcotics for the pain, just be aware that if they still have their gallbladder and they have gallstones, that again, morphine's not the best choice for that. There are other narcotics they could be using. And then Zofran and Compazine if they're having nausea. They might also order statins to help lower cholesterol and decrease development of stones in people that have high cholesterol and a history of gallstones. Couple different treatment options for patients that need a gallbladder removal or cholecystectomy. So remember the last part of the word, the ectomy part, that means removal. So cholecystectomy means a removal of the gallbladder. The preferred method of a cholecystectomy is going to be laparoscopically, and that really decreases the risk of complications, and they have a hospital stay of less than 24 hours. Some of them are going to go home that very same day. So with a laparoscopic one, they're going to have 4 to 5 incisions. Most of the incisions are going to be made to put the equipment in, and they'll have a small, like a little bit larger incision to take the gallbladder out, as opposed to an open one that's going to have quite a much larger incision. So once they're accessing this, you can see here, this is the robotic or the laparoscopic procedure. This is the tools coming in to do the surgery. So it's much smaller. access site. And then when they go to remove this part, they'll make a bigger incision just to be able to get that gallbladder out. Because remember, it's swollen, it's infected, there's some edema going on. They'll have to have a larger access. So when they do the consents for these, most of the time they're going to automatically just do a consent for the laparoscopic procedure, and they'll put on there with a possibility to do an open. So when they get in there, if they can't manage the site with a laparoscopic, they could end up going with an open, and the patient's not going to know that until they wake up. So that depends on the severity of the situation that they might be converted to that option. So a patient might also end up with a T-tube, and this is inserted into the common bile duct to maintain patency of the duct and to promote drainage. This is performed when stones are lodged there and the common bile duct is swollen. So the stones are really going to cause a lot of swelling. The bag, you want to make sure that it's below the site. It's not really that way in this picture. Sometimes it's hard to find really good pictures of examples to show you, but just kind of like a Foley, you wouldn't want a Foley to be at the same line of the bladder. The same thing with these. So this really needs to be lower than the access site there. You want a Fowler's position. That's going to promote drainage by gravity. And the site care, you want to protect the skin from leaking of the bile. So these are notorious for leaking. So you want to make sure that you're checking that dressing, making sure skin's intact. A lot of times there's a barrier spray that a hospital will have, so you'll remove the soiled dressing, cleanse the area with soap and water or normal saline, and then you're going to protect that with a spray, like a little barrier spray, to kind of puts a second skin on that skin. So they might have this for 4 to 6 weeks, so they're definitely going to be going home with this. Some patients do have it longer. And then make sure that you're checking your orders, because some of these you have to flush. There's a little port on here somewhere. I can't really see it in this picture. So I found a picture real quick I'm going to show you, maybe. So it kind of, this is not really the same kind of valve, but it's very similar to a Lopez valve. I couldn't find a picture of it. So you would flush, there'd be a little valve like this on the T-tube, and you would forward flush only with normal saline, and that just kind of keeps the line open. And this right here, you can see that this is going into the common bile duct, and I want you to notice, I don't know if you can see it real well, but that is actually shaped like a T. Little bit better picture right there for you. So it goes in the common bile duct right there. So it's a T-tube. So again, nursing considerations, you want to make sure there's a proper connection. Bag below the site, so this is improper right here. Maintain drainage, chart your color, your consistency. Maintain Fowler's position, do your skin care, and if they're going home with this, educate them how to take care of it. And there's a separate slide for you right there with information. And you can see in this picture where they're inserting the T-tube for drainage, right through the insertion site and into the common bile duct. That is called a choledocostomy. So, taking care of these patients post-operatively, they're going to have some pain, quite a bit of gas pain, because when they make these little incisions, they kind of puff them up with air. That way they can visualize the site better. So you want to make sure that you're ambulating these patients early to help decrease that pain and immobilize that gas. You're going to advance diet as tolerated. So they're going to start off pretty slow with this. They're going to do clears. So you want to start off with ice chips, and clear is going to be anything you can see through. So milk would not be clear, but juice could be, as long as it's not real pulpy. And the advancement of the diet is really at your discretion as well as patient input. You want to provide education and reinforce teaching. So good patient education is really critical with these patients because they're discharged post-operatively to home. So some of them might not even go to a hospital room. Some of them might get discharged in the recovery unit right after they leave the PACU. So it's a pretty quick process there. These incisions, you'll see that they're kind of high on the abdomen. You might even see one in the umbilicus. These patients don't like to cough because of it, so they don't like to use their incentive spirometer. You really want to educate them on the importance of that to prevent atelectasis. So splinting, incentive spirometer, early ambulation, and pain control. Education on all those points is going to be critical. So lithotripsy used to be pretty common. It's not really the best choice anymore, and it's only really done if a patient is not a good candidate for surgery. So ultrasound is used to align the stones with the source of shock waves, and that's used by computerized lithotripter. So again, it's not as common as it once was. The patients might lie on their stomach, and the positioning is of the utmost importance during the procedure. So this takes about an hour, and the shock waves dissolve the stone. They might give a little bit of light sedation for this, especially if they can't tolerate being on their stomach. This, I will upload this PowerPoint to D2L. That way you can see some of these videos, because especially when it comes to patient education, you really want to make sure that you know how to take care of that T-tube. And a lot of times the patient will like to see the surgery before they have it. Dietary considerations. When these patients first come into the hospital with an acute TAC going on of cholecystitis, you want to make sure that they're NPO. A couple different reasons for that, because sometimes the food makes this pain worse, and also you don't know if you're going to need to send them for surgery. So make sure that you make them NPO. They might have an NG tube inserted to help relieve any nausea, vomiting. This depends on how severe it is and how much distress the patient is having. So post-operatively, or even if they send them home without surgery, you want to make sure that you're having them eliminate any dietary fat. So that means whole milk, fried foods, gravy, and potato chips. They're not going to like it, but if the pain's severe enough, they'll comply. And if they have any bile flow obstruction, they might be giving them some fat-soluble vitamins like A, D, E, and K, or bile salts, and that may be given to assist with the digestion of foods. And patients aren't really able to absorb fat very well with an obstructed bile flow, so that requires some supplementation. Your nursing diagnosis here, so they're going to have some pain, and that's going to be with or without any type of surgical intervention. So increased pain after eating and increased fat in the diet. So NPO, pain medications. You want a Fowler's position because that decreases pressure on an inflamed gallbladder. So positioning is very important. Imbalanced nutrition, less than body requirements. You want to make sure you get a dietary consult, get the dietitian in there to see them. Vitamin supplementations, especially fat-soluble vitamins, because they're not absorbing fat very well. And then infection, so especially with cholecystitis, the biliary cirrhosis, this bile backs up to the liver and damages liver cells. Monitor vitals, assessed abdomen every 4 hours, antibiotics, cough, deep breathe, and reposition, especially for the patients post-op too, and think about your patients that might have had a perforation. So all very important. Lastly, I just want to go over gallbladder cancer just briefly, just to touch on it. I don't have a slide, but since it is in your textbook and they talk about it, you need to be aware. So gallbladder cancer, it's very rare. It's usually over 65 years of age, and it's more women than men. The diagnosis is delayed. Early symptoms mimic a lot of other GI disorders, so it's kind of easy to miss this. So manifestations are intense pain, a palpable mass over the right upper quadrant. Think about the location of your gallbladder, some jaundice, and some weight loss. Usually this metastasizes to the liver, and the treatment is usually due to advanced cases would be surgery. So nursing care is more palliative and focuses on comfort and independence. And that wraps up the gallbladder.